Okay, great. So in 10 minutes, hepatitis C. So I'm going to really focus on where the field is going. So hepatitis C is just as relevant today as it always has been in New Zealand. We have an estimated prevalence of around 50,000 patients. That's just over 1% of the population. And the big concern is about 50% of these, so 25,000 patients out there, don't know that they have it. We know that hepatitis C is a silent disease, and over a process of about 20 to 25 years, it can progress through stages of fibrosis to cirrhosis. And again, more relevant in this day and age is with the epidemics of obesity and the metabolic syndrome, factors that can increase and accelerate this progression. Hepatic steatosis, diabetes, and of course alcohol and co-infection with other viruses. And ultimately, 1 in 5 patients with chronic hepatitis C will end up with cirrhosis. And of course, this leads to the end-stage complications, which we all fear: liver failure, which can happen quite quickly, and liver cancer. And the only effective therapy, should the patient be eligible for these, is really liver transplant. And hepatitis C is still probably the biggest cause worldwide for listing for transplant. Obviously, that's not accessible to many people. So traditionally, we have instituted treatment fairly late on, mainly to prevent patients progressing to cirrhosis, but also limited by tolerability, patient side effects, complex regimes. But this is changing. We really want to get treatment in early because the goal is changing. And the goal of hepatitis C is not just to prevent complications, but actually eradicate hepatitis C from New Zealand. And New Zealand is one of the countries that has signed up to achieve this quite lofty goal. Now, obviously, this requires a multifaceted approach, and we need, firstly, to increase awareness, reduce stigmatization, get these people, identify them, get them tested, and then encourage them to be treated. And this is largely possible because of the new treatment regimes that we have available. So this is one example of one of the campaigns. There are a number of campaigns that are aimed at trying to make hepatitis C testing seem okay for everyone. This is from hepcinfo.com. That's a very useful website. And as they say, as I've said before, about 25,000 Kiwis out there don't know that they have Hep C. So a normal person, not just targeting the IV drug users, come forward and get tested. We don't have a mandate in New Zealand as to who should be tested, so we rely on you guys and patients to sort of try and get tested themselves. But in France, there's a universal testing. They screen everyone. And in America, they have a specific cohort of the baby boomers. They just test everyone just to sort of decrease the stigma. So what do we do? What do we need to do? There's not really much, actually. We just need to confirm the presence of active replication with the RNA. In New Zealand, there's really 2 main genotypes, genotype 1 and 3. An assessment of liver function with the standard tests. You have to tick the box for an AST separately, but that is quite useful for a biochemical assessment of fibrosis with the APRI score. We should check for co-infection with hepatitis B and hepatitis A, and if these patients aren't immune, they should be offered vaccination. And then they need some sort of fibrosis assessment. So I mentioned the APRI score, so that is the AST to platelet ratio index. And that's quite a simple but quite reasonably robust as far as non-invasive blood test scores go. If a score is less than 1, then it's very unlikely the patient is cirrhotic, and they can actually be treated in primary care. If you need a more thorough assessment, then FibroScan or shear wave elastography can be performed. Usually those are limited to certain hospitals. Now, as I mentioned, we're now in this interferon-free regime, and the direct-acting antivirals, they're somewhat complex, but there's basically 3 main classes: the NS3-4A protease inhibitors, NS5A and NS5B inhibitors. And I've just listed the ones that are relevant to us here in New Zealand. Now, these are often used in combination because hepatitis C is it rapidly mutates and rapidly replicates. So we have the combination of paritaprevir boosted with ritonavir, combined with ombidisvir and dasabuvir, that's known as Viekira Pak. Ledipasvir and sofosbuvir is known as Harvoni. And the new kid on the block is glyceprevir, known as Mavorite, and that is going to change how we treat. So currently, Pharmac funds Viekira Pak for patients with genotype 1. And non-cirrhotic patients can be treated, as I mentioned, in primary care, and generally, by and large, there's a greater than 95% cure rate with Viekira Pak for genotype 1. Harvoni is funded only for decompensated patients, so those with a MELD or a model of end-stage liver disease score of greater than 15. So that's something that we do in the hospital and select patients. We have to apply for special access for that. Pegylated interferon and ribavirin for other genotypes, yes, it's technically still funded, but we're really trying to avoid this because we do have the other better regimes. You'll probably have a number of patients out there who want to self-fund and pay for it themselves, and if so, they can be treated, any genotype, and the best way is with the Hep C Buyers Club or fixhepc.com. This is quite a thorough website, and what they do is they import the generics to New Zealand through the legal channels, and probably the most useful combination is sofosbuvir and declatovir. And that will probably cost a patient around $2,000 for a 12-week course if they want to self-fund. But most of our patients can't. So for those who take Viekira Pak, it's for the majority 12 weeks. Yes, there are some interactions, so we do need to check for those. Ribavirin is used if patients are genotype 1A. It's weight dependent, so it does need to be adjusted based on their weight. And monitoring is fairly simple, actually, as far as hepatitis C goes. At 2, 4, and 8 weeks after starting treatment, we need to check their liver tests, and if they're on ribavirin, a full blood count, so that we can adjust the dose of ribavirin if they develop anemia, which is one of the side effects, or if their renal function drops. And because there are a number, there are 4 agents combined. This is an AbbVie-sponsored care program, and you name the pharmacy does all the education, and you can see this is the patient's sort of daily pack, so it's pretty foolproof, and then they get a little card that tells them how many ribavirin tablets, because that may be a little bit variable. To test for cure, we now just get a hepatitis C RNA 12 weeks after completion of therapy. That's all we need. We don't need it during treatment at any other stage. As I mentioned, there are some interactions with Viekira Pak. The best site, and we use this all the time for every patient, is hepcdruginteractions.org. If you just type this into Google, Hep C drug interactions, it will lead you to this site. This is developed by the University of Liverpool. It's very simple, so I've just started typing in Viekira Pak, and it already comes up with the agents. So this is Viekira Pak here. Tick, typed in amitriptyline just as an example. Tick, and it gives you a little drug interaction checklist. Because these are metabolized through the CYP450 pathway, and because of the protease inhibitors, there are a number of medications that will be absolute contraindications, and particularly some anticonvulsants, some statins, so atorvastatin and simvastatin, and some antifungals. Patients can't be on the combined oral contraceptive, and you can't use it in pregnancy because it hasn't been tested in pregnancy by Viekira Pak. And then, of course, ribavirin does have some other slight side effects we need to just monitor for. But as I mentioned, this will change, and hopefully this will be funded very soon. We keep sort of waiting and waiting, and we get told maybe next month, but should be around the corner. Mavorite, which is a combination, a simpler regime. This is pangenotypic, 2 agents, glyceprevir and pibrentasvir. This will achieve a greater than 98% cure for everyone. The suggested model of treatment will be for primary care. 8 weeks, you guys will be able to treat the patients if they're non-cirrhotic, and then maybe refer us the more complicated ones. So this is exciting times ahead, and there'll be obviously more talks to come in this in the future. So in summary, hepatitis C is still a major health issue in New Zealand, and 50,000 people, 50% unaware. Treatment is effective with a greater than 95% cure. The goal is now shifted to wanting to eradicate hepatitis C, and really we need to get out there and encourage testing and treating. Thank you.